KSOS for this opportunity. The first topic is preoperative evaluation in posterior polar cataracts. Posterior polar cataract usually presents as a well-demarcated disc-shaped opacity located in the center of the posterior capsule. It is a rare form of congenital cataract. Autosomal dominant inheritance is most common, while sporadic non-familial mutations occur. Several gene mutations are associated with it, which cause dysplastic lens fibers to migrate from the equator towards the posterior pole, and they form the discoid plaque. When it is associated with genetic mutations, it is usually bilateral. When it is associated with remnants of tunica vasculosa lentes, it is unilateral. Stationary type is more common. Progression occurs as whitish opacification changes in the posterior cortex, and with time they form concentric rings like a PSC around the discoid opacity. The most important differential diagnosis is a central PSC. In central posterior subcapsular cataract, it will be granular in appearance, while the other one will be a discoid plaque. And also the posterior polar cataract shows a cone-like anterior projection. There is high incidence of PCR. Varying rates have been reported from 7% to 36%. This is because of the heterogeneous relationship between the plaque and the posterior capsule. So why there is a high incidence of PCR? Because of the tight adherence of the plaque to the capsule, and also the plaque, the PC underlying the plaque is exceptionally thin. Pre-existing PC defect can be seen in 20% of cases. Both stationary and progressive types of posterior polar cataracts can become symptomatic with age. Usually they become symptomatic after the age of 30 years. The most common symptom is due to glare. There is stray light related complaints, difficulty in reading fine print, and reduced contrast sensitivity. With age, there is increasing density of the opacity, age-related pupillary meiosis, and increased functional needs, which make the PPC more symptomatic. So the indication for surgery is a visually significant cataract impairing the patient's quality of life and activities of daily living. It is very important to note whether the PC is intact or there is a pre-existing PC dehiscence in the preoperative assessment. Slit lamp examination is important. A careful slit lamp examination with retroillumination, we can diagnose the PPC, and we have to assess the visual significance of the lens opacity. Is there any evidence of PC defect? And if we see oil-like droplets in the anterior vitreous, it may point towards a pre-existing PC defect. Classification into clinical categories like with an intact PC, with a pre-existing PC dehiscence, and spontaneous lens dislocation. Daljit Singh classification is very important. The type 1 posterior polar opacity is associated with a subcapsular cataract. Type 2, a sharply defined round opacity with an onion ring with or without grayish spots at the edge. Type 3 means it is more progressed. There is the sharply defined round white opacity with a dense white spots, which is called the Daljit Singh sign. And type 4 is a combination of all the three types with nuclear sclerosis. Ashwin et al. Have done a large study of 388 posterior polar cataracts, and they found that with the Daljit Singh classification, 75% of eyes with type 3 had intraoperative PC rent, while only 3.4% of eyes with type 1 PPC had an intraop PC rent. ASOCT is a very important tool now. Since 2014, various authors have described different ASOCT-based observations with attempts to segregate the deficient capsule from the intact one. it is very difficult to assess the capsule behind the plaque by slit lamp. So we need a cross-sectional imaging which is provided by the ASOCT. Here we can see the intact PC, while here the PC is deficient. It was first Kaimionis in 2014 who started the study of ASOCT in posterior polar cataracts with C's Visande machine, which is a time domain machine. He studied it in 3 patients where slit lamp there was no detectable PC defect, but ASOCT in 2 cases there was defect, and it was confirmed intraoperatively. These are the major studies which have looked into ASOCT and posterior polar cataract by Chan et al. Using C's Visande machine, by Pavan et al. Using C's Visande machine. Pujari made an innovation, that is, he attached the 20D lens over the aperture of the usual posterior segment OCT. And Dhanashilan used the Cirrus 5000 with an ASOCT module. So we can see the sensitivity and predictive values of each of these studies, and we can see that it is a high number. And this shows that because of the high predictive value, if a negative predictive value, if the posterior capsule is found intact on ASOCT, the chance of an intra-op PCR occurring is very less. Now the swept source ASOCTs are coming, and the Pujari et al. Have done a study with KSOS, which is a swept source OCT. It gives better images from the anterior cornea to the PC in a single frame. So they have looked into 2 aspects. One is the extent of capsular visibility, and the second, the contour of the posterior opacity capsular junction. So they have classified it into various forms. The generalized form, the type 1 variant showed little separation between the opacity and the capsule. Here there is more chance of PCR intraoperatively, while here we can see hypoechoic areas between the opacity and the capsule where the incidence of PCR intraoperatively was less. Then specific morphologies like conical morphology, mouth-eaten morphology, and ectatic morphology were noted. The conical morphology, the usual convex contour is lost, and through the deficient capsule, there is extension of opacity into the anterior vitreous. In moth-eaten variety, there is deficient capsule and there is a clear area in the opacity. In ectatic morphology, the PC is intact, but it is weak, so it shows multiple ectatic bulges along the anterior vitreous. So based on the OCT, in an intact PC or clear hypoechoic area between the posterior plaque and the capsule, there is lower risk of PCR, while specific morphologies showed an increased risk. ASOCT is a valuable tool to assess PC integrity. The importance is that we can segregate low-risk cases from few high-risk cases. UBM ultrasound biomicroscopy has a role when there is a dense media opacity and the PC cannot be clearly visualized. Early intervention can be considered because when the nucleus is soft, the technique is easier, and also there is chance of progression over time. And especially in childhood, if it is visually significant, it can cause amblyopia. So detailed counseling is very important. The higher chance of PCR, need for alternative IOL fixation strategies, NDA capsulotomy for the residual plaque may be needed, and amblyopia. The red flags to look out for is the pre-existing PC defect, Daljit Singh classification type 3, more than 4 mm of a plaque size, and ASOCT features suggestive of PC dehiscence. So careful preoperative evaluation is the key in recognition of PPC, and further testing like ASOCT assists with risk stratification and surgical planning. Thank you.
Thank you, Dr. Sara, for that comprehensive overview of evaluation. It's true that forewarned is forearmed. Now that you know that there is a posterior polar,